Yeah, just going to go over a few things from last week and this week to come. So last week, week 4, we looked at health policy in relation to health insurance coverage as well as interest groups. And hopefully, our written assignment gave you a good idea about interest groups and their impact. Just even looking at some of the spending and those types of things associated with interest groups, it is a pretty big deal. They spend millions and millions of dollars trying to get their particular point of view across to our lawmakers and to the president. So, important elements there to be aware of. We also had our final topic choice to be submitted. I will be reviewing them this week and getting info back to everyone on those. The final project will be due in week 7, obviously, but taking a look at those. Just for kind of a second set of eyes. I sometimes have folks, I think I mentioned this last week, but I sometimes have folks that try and take what would really be like a policy of a hospital or a health insurer or something of that nature and turn it into health policy. And remember, when we're talking about health policy, we're talking about governmental and regulatory issues, not organizational policy. So just be on the lookout for that. Those will be coming up soon. So week 5 is more about policy implementation. So talking about how we implement policy in different situations, and then also issues associated with Medicaid. We'll have some info on that as well. So our discussion this week, obviously, hopefully folks are already hard at work on it, but looking at policies, state or national policies that are kind of in the process of approval. So there's lots of them out there. I think there's some surprise billing legislation out there. At the state level, unfortunately, I don't track anymore. I don't live there anymore, but I've given you a link as to how you can find some of that. So we're looking for something that hasn't been approved yet, something that's going through that approval process, and you can find lots of. You'd be surprised at the number of bills in process that never get any further than just that situation there, just something that's being looked at. We also have a case study this week. Case study itself is noted up here. So let's review our quiz from last week. So a few questions here. When patients responsible for paying part of the cost of care, the patient is more likely to use that care. The answer to this is false. I was surprised that, and maybe it's just the way it was worded was confusing. I don't see that, but I guess sometimes folks see things differently than me. But this is moral hazard. So it's what we've talked about already in class. But moral hazard and the notion that if something costs less to a patient directly, they're more likely to use more care. So if you have a patient who is 75% of their services covered, they're probably less likely to use healthcare than someone whose coverage level is at 95%, because the 75%, they know they're going to have to pay that 25%. So the patient is less likely to use the care if they are responsible for paying for part of it, and that's moral hazard. Actually, kind of the opposite of that is moral hazard. When we have great insurance plans that cover almost all of what we would owe if we were self-pay, we're more likely to use more care. Next question, majority of uninsured people in the U.S. are, the answer was working for low wages or for small employers. So think about, probably the question or the answer that was chosen more often than not, if you got this wrong, was without a job or a source of income. And most of the folks that are without a job or a source of income are eligible for Medicaid. So because if you're, depending on what state you're in, because it's all state driven, but if you're even above the poverty level, if you're a certain percentage above the poverty level, you're eligible for Medicaid. So if you have no income, then you're definitely eligible for Medicaid. So you would no longer be uninsured. You would have Medicaid as your insurance. However, if you're working for low wages or for a small employer, you might be in a situation where not all small employers are required to provide insurance to their employees. It depends on how many FTE or full-time equivalents they have. So you may not have access to coverage through your employer. Or if you're working somewhere for low wages and those wages are just getting you by week to week. So if you the amount of money that you make. Maybe you're making minimum wage working at a fast food place or at a grocery store or something of that nature, and that's the amount you make. Is you need all of that. They're going to take taxes out, but you need all of that. You don't. The grocery store may offer you healthcare coverage, but it costs you another $100 a week or something. So sometimes patients or folks, generally, not necessarily a patient, but sometimes folks go without health insurance coverage just so they can have the additional money in their paycheck to be able to pay for food and rent and all those kinds of things. So that's a problem in this country. It's puts patients in a bad situation when they do need to seek health care, because they have access to health insurance coverage, but it's too expensive. So it's a problem that we need to address in this country. And the first start of that is decreasing costs in healthcare. So if cost goes down, then insurance costs can go down, and then hopefully it'll be a positive cycle that eventually would allow everybody to be able to afford appropriate health insurance. And that's the argument with that. There's lots of people that argue that healthcare is a right, not a privilege, and that everyone should have access to free health insurance through the government. That won't work in this country, given our current system, just because physicians aren't used to working low-paying government jobs. So we would need to have really an entire fell swoop change of the system, which we already are in a situation where physicians and nurses are in short supply, and a lot of that is due to the heavy workload and that the pay doesn't balance it out. So imagine a situation where we go from physicians being paid six figures to physicians being paid 50 grand a year, and the workload is not going to balance that out. And it sounds ridiculous that that physicians would need to make that much, but think about I think about myself. I owe about $150,000 in student loans. So think about that for physicians that also go through many, many years of schooling. It's not like it's free. So somebody needs to pay back those student loans. My student loan, actually, I'm happy that they're in deferral right now, but I just got a notification that my student loan payment is going to be $2,400 a month in January when it starts back up, or February, I guess, when it starts back up. So you can't work a job that won't allow you to pay for food and housing and your student loans. So there needs to be a change in the system somewhere, and I'm not sure where that needs to start, but it needs to start somewhere so that folks can make an adequate wage based on the stress and strife associated with the job, but also being able to pay their bills. And if people aren't going to be able to do that, then nobody's going to want to go into those fields anymore. So it's not necessarily about being rich and driving a Lexus. It's really about being able to pay bills in some instances, especially when you have physicians that do work in government jobs right now and aren't paid very well. So just a commentary on that, but something to think about. Next question. Majority of those uninsured in the U.S. are minorities. So this is noted in the on page 234 in your textbook. On the bottom of the page, there's a little chart. So as the chart says, and actually it's pretty. It is a majority, but it's a slim majority. So 53%. If you add the sections for Asian Pacific Islander, Black, and Hispanic, that equals 53% of those folks on the chart. So that is a majority, obviously, and the biggest chunk on the chart are for white folks that are uninsured, but it's only 47%. So it looks like, if you looked at it quickly, I can see where you might have confused that, but the total amount of those that are considered minority in the U.S. is 53%, as opposed to the portion of the population that is uninsured that is white, which is 47%. So hence the answer is true there. Last question, 75% of the funding for the Medicare program comes from, and if you're working a job in the United States and you take a look at your paycheck, you will see, likely see, it depends on how much you make. If you make very little, like as a student worker or something of that nature, you may not see this, but generally you'll see a line that says Medicare, and you'll see a chunk of your paycheck that is associated with the Medicare program. And the point of that is we pay in throughout our lifetime, and then when we reach 65, or if we become disabled, then we're able to use the Medicare program. You do still pay premiums for Part B Medicare, but it's a mere pittance compared to how much you've paid out over, 40, 50 years. So it's important to know that those general tax revenues are 75% of the funding for the program. However, what's kind of problematic about it, and that's kind of the purpose of this class, is to dig into some of these problems. It's highly unlikely that program is going to be around when we get around to being able to use it. So we're paying in a lot more than people that came before us because wages are much higher now. Granted, costs in healthcare are higher as well, but we're paying in more. And even myself, it's somewhat unlikely that in 15 years, when I'll be eligible for Medicare, that it'll actually still be there. So it's problematic that that's where the bulk of their funds come from folks that perhaps will never be able to use the program. But that's how the program was built. So, and that is the nature of government-funded healthcare. So, for folks out there that I know, there's always a good number of people that are really interested in a kind of a socialistic view of medicine. Medicare for all, everyone receives care from the government as opposed to from private insurers. Someone's got to pay for that. So think about the amount that comes out for Medicare right now, and multiply that by the additional number of people that are currently existing and would be accessing that program. There probably wouldn't be a whole lot of the paycheck left if it was just paid for out of tax revenue like Medicare is. So there needs to be a different way. That we need to look at it in a different way, a more something more creative, something that can give us some additional funding, but not necessarily just via tax revenue, because that's not the answer for sure. And that's all I've got for this week. Hop back to the classroom. If you have any questions on your paper, your case study, or anything for this week, let me know. Be sure once you see that the topic section has been graded, please, let me know if you have any questions on my feedback. I'll try and give you as detailed feedback as I can. Or you might see me asking you for more information, depending on the situation. So just keep an eye out for that. And everyone have a good Thanksgiving holiday. Hopefully you'll be able to take a little bit of time with friends or family or both, and just relax and eat some turkey or whatever it is you prefer on Thanksgiving, and give some thanks for the fact that we all made it through the pandemic fairly successfully, and thanks that it looks like it's kind of in a downturn. So, and give thanks for everything else that you're thankful for, obviously. So have a great week, and I'll talk to you all next week. Thanks.